Good morning, respected judges and dear teachers. I would want to start my presentation with a practical problem that we face in our OPD. So this is a patient who had received 3 anti-VEGF injections, 2 DEX implants and 4 sittings of laser. But despite that, you can see there is a huge amount of cystoid spaces in his center involving. So what would we go about treating these patients? It's pretty difficult to analyze. So we fumbled upon a certain solution, which is my further talk upon. So ask the patient to look through a particular filter to the sun, and what happens after this. You can see at 1 month, the CMTS decreased by around 30 microns, and at 3 months, it's coming down by around 40. At 5 months, it's approximately about 60 microns to 70 microns less than what to begin with. I just want you to note at 7 months something's happening, the edema is coming back a little bit again. So this is all my paper is about. So it is photobiomodulation in diabetic macular edema, which has been resistant to standard treatment, which we do nowadays. So the purpose of study to evaluate the effect of photobiomodulation for eyes to resistant or recalcitrant diabetic macular edema. And we took the worst eye. So the patient usually presents with bilateral edema, maybe symmetrical or asymmetrical. So we took the worst eye because we didn't know whether it really works. And second, needed to see that we are not causing any further harm to the already existing problem in the retina. So the concept was, we took a yellow filter. Why did we take a yellow filter? Because it's the most macular friendly laser that we are available at present. So we took the subthreshold idea which was present, because if you look at the continuous wavelength laser, it causes much damage to the RP and the photoreceptors. So we didn't want that, we wanted a subthreshold level. So we took the subthreshold level, we took this filter and validated at Indian Institute of Science, because we wanted the filter to pass only something between 570 to 580 nanometer of wavelength. So how did we do the study? We asked the patient to expose the eye, which has to be scheduled for the treatment, for 5 minutes per day early in the morning, 9 to 10, 5 days a week for 1 month. So that's it. Stop the treatment at 1 month and then follow up the patient prospectively. Only one eye was treated, as I had already mentioned, the worst eye. The fellow eye had acted as a control. So the review was at 1, 3, and 6 months. So how did we ascertain that the amount of energy that was delivered or whatever it is? We took a light meter, we measured the sunlight energy in lux and then converted into the energy prospector there. So most of the focal laser or the macular painting that we do nowadays in subthreshold level gives an energy of 3 to 5 millijoules. So that's why we aimed at 5 millijoules, and that we calculated at 5 minutes. So method, it was a prospective study. It was done at Shankaraya Hospital, Bangalore. Duration of the study was for 2 years. We included 11 eyes from 11 patients. The inclusion was diabetic patients who are more than 18 years with recalcitrant diabetic macular edema, and adequate systemic control. There shouldn't be any bias in that. Willingness to follow up and give consent. The exclusion criteria was anything which causes a bias in the treatment response. So anything which had a poor response, and then we could say that it controlled well so that the edema come down. So any poor glycemic control or hypertension, nephropathy, we eliminated out. So what did we assess? As far as the eye is concerned, we look into the CMT very closely, the multifocal EIG, and the Humphrey visual fields to make sure that we are not losing upon any of the, there's no harm done to these patients. So did it really help? That's the golden question that we asked. That's what I'm presenting. This is the second patient. One patient I've already presented. So see at what happens at 1 month and 3 months. The CMT is gradually coming down. It's seen on the end-face image as well as the cross-sectional image which is there. The third case, this patient had received 3 injections, 2 DEX implant again, and he has already undergone a PPV because there was some amount of doubt of element of a thickened posterior hyaloid. And see what happens. The edema is still coming down almost about 280. This is one of the most highest responders in the group which we had. So did we do any harm? We took the Humphrey visual fields and matched. You can see that the scotoma, which was initially present, it decreased down over a period of time. And even the multifocal EIG, the foveal peak was still maintained very well. So did all respond? So all the 11 patients, did they respond? We could see like we arbitrarily divided these patients into 3 categories, though any response should be considered as positive. So we eliminated whoever responded less than 50 microns and selected only who had responded more than 50 microns of decrease in the CMT. And nearly 70% of our patients respond favorably with decrease in the central macular thickness. The range of response was anywhere between 18 microns to 291 microns. Now, the proof of concept, did it really, was it by chance or whether it really responded? So first and foremost, we'll see when we are exposing the patient to the treatment, did it really respond? So this is the treated eye. So you can see that the edema is coming down. In the same time, we followed up the fellow eye. In the fellow eye, you can see that during the same period, the edema is increasing up. It's not stable or it's not decreasing. When we stop the treatment, so the first patient also I showed, this is another example. At 5 months, when we stop the treatment, the CMT is coming back again. So it tells me that when I'm giving the treatment, it's responding, the fellow eye is decreasing, increasing edema, and once we stop the treatment, the edema is coming back. So looking at the implication, it's a very simple but an effective technique. Functions like subthreshold laser, it's rather rejuvenating the retina and RP and decreasing the edema. Future, when we look at it, if we add upon to the existing conventional treatment, can we decrease the burden of treatment per se or repeated injections? And over a future of time, whether it can act as a primary modality of treatment. Limitation of study, you know that we have very small sample size, only 6 months of follow-up. Variable sunlight available, sometimes it's cold, sometimes it's warm. So how do we appropriate? So we try to patients have phones which have light meters. They can measure the light meter and then go ahead with the treatment, and app for monitoring. Validation for larger cohort and long-term treatment has to be validated.
Thank you. Interesting study. Any comments, please? Well, I think with this we come to the end of this session. Thanks all of you for this